So welcome everybody on World Menopause Day. It's so fabulous to have you all with us. My name is Alice and I work for Fertility Network UK. I'm the Wales coordinator. So Fertility Network UK, for those of you who don't know, we are a fertility charity and we are here to provide impartial information and emotional support to anybody who is going through any type of fertility journey. We work with young adults to educate them on their reproductive health and some of the things that can impact their ability to conceive in the future and what they need to be aware of. We obviously support those who are going through investigations and treatment, and also we support people who are childless not by choice but by circumstance. So right across the journey, from education to the workplace and beyond. I am so happy today to be joined by two fantastic organisations. We have got the Daisy Network with us, both Amy. Amy's joined us, she's the chair and she's also of the Daisy Network and she is a counsellor. Amy's going to be talking a little bit about her personal experience of living with POI and how it's impacted her. She feels passionately about raising awareness of the condition and also making people feel if they've had a diagnosis or if they are on the route to getting one, she wants them to feel less isolated and get the medical help and the psychological help that's needed. So thank you, Amy, for being with us. We've also got Kate Maclaran, who is a trustee of the Daisy Network. And Kate is obviously also a consultant gynaecologist and subspecialist in reproductive medicine and surgery. Kate has a special interest in premature ovarian insufficiency and assisted conception, low ovarian reserve, amongst various other things. So Kate is going to be really here to run through everything from symptoms to treatment to options. So a fantastic opportunity for you all to ask the questions that you have. So welcome, Kate. We've got Sarah Williams, who is a workplace consultant and trainer with a background in equality and diversity and governance support. So she's now working to advance equality and inclusion for those affected by menopause at work and in the community. And lastly, but by no means least, we have our Emma, who is my colleague at Fertility Network UK. And Emma is going to be also bringing a bit of a personal insight. She underwent fertility investigations and treatment for many years, and she's going to talk about how it impacted her within the workplace, and kind of what she had to go through and what improvement could and should be made as well. So thank you all for giving your time today. I think we will start now by starting asking Amy some questions, if that's all right, Amy, and then we'll go from there. So first of all, Amy, POI, a lot of us don't know a huge amount about it. When did you become concerned about your periods, and when did you go and seek medical help?
Yes, so I suppose it was actually my mum that was concerned rather than me, because I was 15, I still hadn't started my periods, and I have an older sister, so my mum thought something's not quite right. By 15, something should be happening. I was very small and underdeveloped. So it was my mum that really dragged me kicking and screaming to the doctors at 15 to kind of see why I hadn't started my periods. Yeah, and the doctor said, give it another year, wait till you're 16, and then they will do some investigations.
And when you went back to the GP, Amy, what did they do? What investigations did you have?
Yeah, so I went back at 16, still nothing happened, still no period. So I underwent some blood tests, and they found that my brain was firing FSH at my ovaries, but they weren't responding. So that's when they kind of realised, yeah, something's not quite right here. I wasn't really given an official diagnosis of POI or given sort of the right terminology. I was just sort of told that my ovaries aren't working as they should be.
Okay, so when did you then go and have further investigations? At what stage did they kind of look into things further?
Yeah, so after that, I was then sent to an endocrinologist who specialised in sort of children. And that's when I had sort of further investigations, a lot more blood tests to see if they could find out a cause. They couldn't. I then had sort of an ultrasound to find out that my ovaries were really underdeveloped, especially one of them was practically non-existent, and that I wasn't producing any eggs, so I wasn't ovulating, which then consequently meant that I can't get pregnant via the natural route.
And what about symptoms? Kind of what sort of symptoms did you have, or?
Yeah, I think because I was so young when I went through it that I didn't have those traditional sort of menopause symptoms that other people have, because my estrogen had never actually built up before it dropped. So I didn't really have any physical symptoms. For me, it was more emotional. So I had extreme anxiety that happened sort of around the same time, and we never sort of put two and two together. But actually, looking back now, it probably was linked to the low estrogen. So that's what my main symptom was just crippling anxiety. Yeah, and then I also, consequently from having low estrogen, I then had a bone scan, and I found out that I had osteopenia in my leg, arm, and hip. I take vitamin D now to sort of keep on top of that, and I get that checked regularly. But that's sort of a symptom and a side effect from the low estrogen.
And obviously with the anxiety, did you ever speak about that with your doctor to say kind of, is this related, or?
To be honest, I think that's one of the main things that I found now looking back, was that there were so many other puzzle pieces that were never really connected. So I went about the anxiety, but the two things were never really put together.
Okay. How does this condition, like, how does it affect your fertility and your options? Have you kind of, where are you with that sort of side of it?
Yeah, so I'm taking my HRT, so my estrogen levels are where they should be. But in terms of fertility, I think I'm really lucky where I live. Up in Newcastle, we have an amazing fertility centre, so that conversation has always been ongoing since the diagnosis. My womb is fully functioning, so I can carry a child should I want to in the future. I've had endless discussions at the fertility centre about different options. One of which being egg donation. I have an older sister. She's always said she would donate her eggs if that's something I wanted to do. I've discussed about sort of anonymous donors. I'm 31 now. I thought I would have decided by now. I still don't know, but those are the options that I've got, and I've kind of explored and had so many conversations about those options. So they are there should the time come where I decide I'm ready to do something about it.
Brilliant. Oh, thank you, Amy. Have you kind of, with what you mentioned, donor eggs, do you know much about that, or have you been given much information about the donor treatment option?
I think I feel like I say, the fertility centre that I go to have been really, really good in supporting myself through those options, telling me about them, or even getting my sister in to go through it all with her, so she would be well versed in the options on what would happen to her if we did go ahead with it. So I do feel lucky on that respect, but I know a lot of other Daisy members haven't had that much information as I have. But again, it's a bit of a postcode lottery, I think.
And how do you manage like this condition kind of with your life and your social life and in work, and does it have a huge impact on your life, or are you very used to it? Like, how do you deal with it?
I think it's changed over the years. I think when I was a teenager, it was very much bury my head in the sand, don't tell anyone. None of my friends knew, so I would just pretend nothing was going on. Now I'm a lot more open with it. I think it just brings up its extra challenges. There's things that I have to think about that other people don't. And I think in terms of psychologically, there's a lot to deal with as well, sort of when you're surrounded by, friends who are getting pregnant or talking about contraception and that sort of thing. You feel like you aren't quite on the same wavelength as them. So I think that's more how it's affected me in terms of my life. It's in terms of the psychological side of things. And of course, there's the hassle of having to keep going for blood tests and hospital appointments every other month and that sort of thing, which isn't ideal. And remembering to take all of your medication. So there's just those additional little factors that you have to take into account every day, I think, that other people don't.
Yeah, and the Daisy Network. So obviously, every person is different, and their situation. But kind of, who uses you? Who comes to the Daisy Network, and what sort of support or information are people tending to be looking for?
Yeah, I think we have a range of people that come to us, but it does tend to be, I would say, either after being newly diagnosed, so they've just been told what they've got and been given sort of our details to come and find the support. But quite often we do find it's women that are years down the line where actually they're at a point now where they think, I really start wanting to find some support for it, because it does tend to be quite an isolating thing. So people do tend to shut off from the diagnosis for a couple of years, and it's only as they've processed it a bit more, they decide to reach out for some support. And I think the main thing that people are looking for is just others who understand, because for all you might have, a partner or siblings or friends, nobody quite understands, what you are going through in terms of, being in your 20s and having your whole life path sort of change in front of you. And for all you can have that support, it's not the same as having others that understand. So I think that's the primary thing people look for, is that connection. But then also it's looking for that medical advice. Like Kate and our other doctors do live chats and things like that, where people just aren't getting the right medical advice that they need, or even access to the right medical support. So it's psychological and medical support that they come to us for.
And why do you think that is, Amy? Why is it maybe difficult for people to get the right information?
I think again it's a bit of a postcode lottery. I think a lot of GPs, for example, they might know how to handle normal menopause, but I think when it comes to POI, there's just not that level of training or understanding. And I think one of the problems that we found in Daisy is that there's not one set route of treatment plans or diagnosis. So like some people might just get looked after by their GP, some might get sent to a menopause specialist, some might get sent to an endocrinologist. So I think it just totally varies on what your sort of GP practice process is as to what level of care that you get.
Thank you, Amy. I want for people to have the opportunity now, if you have a question for Amy, because Amy does unfortunately have to shoot off. But if you have a question, and I know you're happy to answer anything, aren't you?
Yeah, absolutely.
Dealing with symptoms, options, like anything. If you want to ask her now, either unmute yourself and ask, or pop something in the chat. Please do, because I don't know, you're around for another 5 minutes or so.
Yeah, I'll be until past. That's fine.
Fabulous. Okay, so if anybody has any questions now, please do ask, or like I say, just pop them in the chat for us. I think what we'll do now, if there are no questions, let's have a quick look. Here we go. We've got one here. Do you know whether some GPs will provide counselling for newly diagnosed people?
That's something as Daisy Network we've been actually discussing and trying to work on, is actually to provide that service, because ideally what we'd like is for that to be something that's given like as an NHS sort of service to people with this diagnosis. Is actually, this is the medical treatment and this is the counselling that you need. So actually, as a charity, that's something we are hoping to do moving forwards. We currently have a group support, like an online support group that we hold once a month, which is, I suppose, like a group therapy sort of thing that we provide. But hopefully that one-to-one counselling is something that we will do, because it's so important. It's so important to have that and to be able to process the diagnosis, because it does affect so many elements of your life. So is really important, but currently that's not something that's given.
Thank you, Amy. Is your fertility clinic private or through the NHS?
Through the NHS, yeah. Yeah.
Okay.
It's a Centre for Life in Newcastle.
Okay. How long have you had access to it? How long have you kind of been a patient of theirs?
Yeah, so I was diagnosed at 16 and I'm 31 now, so 15 or so years. You know, it's been good in terms of I can just check in when I need to, and have sort of those, I can either have regular appointments or just check in if I have a question. But I will say that sort of the NHS service I've received has been really good in terms of really keeping on top of blood tests and bone scans and that sort of thing. But again, it's not everywhere, unfortunately.
I think we'll cover this in more detail now when Kate talks, because she's going to talk a little bit about, you know, what should happen and within a pathway of care. So we will go over this in more detail. Another question that came for you, Amy, was, have you considered freezing your eggs?
Yeah, so in terms of me personally, that wasn't an option for me because I was so young. I never actually developed eggs as such. It's something that I've discussed with my sister. She's was actually in the process of starting that process of freezing her eggs for me should and when I want them. But obviously with COVID that stopped. But yeah, freezing my own eggs wasn't an option for me. But again, like I say, it was a possibility for my sister to do that.
Yeah, brilliant. Thank you so much, Amy. I think what we'll do now, we'll move on to Kate, if that's all right. And Kate's just going to talk a little bit about clinical symptoms, diagnosis, impact on fertility, and treatment options. Okay, I'll hand over to you, Kate.
Great, thank you. Can you see my my screen there?
We can, but not as a slideshow. So you probably want to click into it as a slideshow first, and then share.
Hello. Yeah, this is where I run into trouble, I think. I can't click into slideshow.
Okay, I'll have a go. Let me have a little go for you. Where were you? There we go. Can everybody see that?
Great.
Yes. Well, then over to you. If you just tell me when you want me to switch to turn the pages, then I'll just do that for you, Kate.
Yeah, thanks. So yeah, thanks so much for inviting me to speak today along with Amy. I've been working as part of the Daisy Network for I think like 6 or 7 years now, and it's just a subject that I feel really strongly about. Alice, you've given me a tough task today, which is to give pretty much an entire overview of POI in 20 minutes, which is a lot. So as you've said, I'm really happy to answer more in-depth questions and things afterwards, but just wanted to go through some of the sort of basics. So if you could flick on there, that would be great, please. So I'm sure many of you on the call will already know this. I just wanted to give you a background into what exactly is POI, because there is some confusion. And I often find that it takes women many years to get a diagnosis made. But essentially, well, World Menopause Day today, what is menopause? It really just means the final menstrual period. And it really occurs when the number of eggs in the ovaries becomes so low, and so the ovaries stop producing the hormones that we need. And in the UK, the average age of menopause is around 51, 52 years. But in some women, the egg reserve can decline prematurely, and so the ovaries stop functioning properly much earlier than this. And you've heard from Amy, so this can even happen in teenage years. And so when this happens, if it's before the age of 45, it's called early menopause, and before the age of 40, it's called premature ovarian insufficiency. And you'll have heard loads of different terms used to describe this condition. So premature menopause, premature ovarian failure we used for years. Essentially, they all mean the same thing, but the accepted terminology now, mainly amongst the health professionals, is that we use the term premature ovarian insufficiency, because it slightly more accurately describes the condition rather than premature menopause. Next slide, please. So what are the effects of POI? Well, to diagnose it, typically people present with irregular periods. This is then combined with low estrogen levels and elevations in the hormones from the brain to the ovary, so the FSH test. And it's the result of this low estrogen that causes many of the effects of POI, so that causes the menopausal symptoms. And estrogen is a really important female hormone for long-term health. So it's really good at protecting the bones, protecting the brain, and protecting the heart. And so women with POI, if they don't take HRT, are at increased risk of things like osteoporosis and heart disease. Obviously, as the egg reserve becomes lower and lower, the chances of ovulation become less. And so that's why it's difficult to conceive naturally. Next slide, please. So spontaneous POI, where it just sort of happens naturally out of the blue, affects 1 in 100 women under 40 and 1 in 1,000 women under 30 and 1 in 10,000 women under 20. But we're seeing more and more now women who develop POI after medical treatments. So most commonly, this is people who've survived cancer treatment and have had chemo or radiotherapy that may have damaged the ovaries, or for people who have had some gynae surgeries, so surgery from ovarian cysts or endometriosis and had their ovaries removed. So actually, globally, the latest estimates say that almost 4% of women experience POI and 12% have early menopause. But despite that, and echoing what Amy said, I think there's a real lack of information and understanding about these conditions. And so it really can feel like a very isolating diagnosis. And that's really at DAISY what we're hoping to change. Next slide, please. Can you just click on as well? There's a couple of animations. If you just flick that on. Yeah. So our egg reserve declines gradually from birth to just a few thousand at the age of 40. And after your eggs decline to below around about 1,000, you go through the menopause. So for most women, this happens in their early 50s. Now, most commonly in POI, you're either born with a lower number of follicles to begin with, or for some reason you lose your follicles more quickly. Now, the frustrating thing with POI is that there's so much that we still don't understand. We don't know why some women are born with fewer eggs or they go down more quickly. And so 90% of women will have all the investigations done and still we come back to them and say, we don't know why this has happened. Around 5% of women will be told that they have a genetic cause. So this is sort of relatively rare conditions like Turner syndrome or Fragile X gene premutation. A lot of women will have family history of having POI, so around about 10 to 15%, but in reality, we don't ever diagnose with a particular genetic mutation. And then there's other rarer things that can cause POI, but these are relatively uncommon. So autoimmune disease, where the ovaries, where the body actually destroys the ovaries, and very, very rarely after certain infections, we see POI. And then, as I've mentioned already, medical iatrogenic, so medical causes is an increasing group. Next slide, please. So I think the symptoms of POI are really interesting, and Amy touched on this already. So most women tend to present with irregular periods or their periods stopping, and it's really with or without menopausal symptoms. So actually relatively few women have the classical menopausal symptoms of hot flushes and night sweats, and just around about 50%. And definitely what we see is really quite sort of non-specific symptoms. So mood, tiredness, sleep, headaches. And so I think this contributes to why it often takes women a long time to get the diagnosis made, because it's not the classic menopausal symptoms often. But I think there's there's estrogen receptors all over our bodies, so they really can cause so many different types of symptoms. So there's almost, you know, if a patient says to me, oh, could this be caused by, you know, my low estrogen, there's very rarely that I'll ever say no, there's no way it is. You know, almost any symptom can be related to the menopause, unfortunately. And often things that we don't talk about, so, you know, particularly relevant, you know, things like vaginal dryness, pain on low libido, pain on intercourse, kind of urinary symptoms, these kind of things that often aren't talked about. So really important to mention these to your doctors when you're seeing them. Next slide, please. I sound like Chris Whitty, isn't that his thing next?
Yeah.
So I just wanted to put this slide up so that everyone was really clear on when to seek help and what investigations you should have when you're being diagnosed with POI. So the guidelines recommend that you should be seeing a health professional for investigations after your periods have been irregular for 3 to 4 months. And of course, many people will have irregular periods and not have POI, but it's really important that you get the appropriate testing at that point. So I would expect if you were seeing a GP and you went to them and said, I've had 4 months of irregular or absent periods, they should be taking a detailed history, going through all your background, your medical history. And then you should be having hormone tests for FSH, LH and estrogen levels. If you still have periods, it's really important that these are done at the correct time in the cycle. So they need to be done between day 2 and day 4 if you're still having periods. If these are elevated to within the menopausal range, really crucially, they need to be repeated again after 4 to 6 weeks before we can make the diagnosis. You can't make the diagnosis of POI based on one elevated FSH result. I would also hope then that the GP would also do other tests, looking for other causes of irregular periods, but also just to investigate the POI a little bit more. So I'd hope that they would do thyroid function. You should have prolactin if you're not having any periods, and also a pelvic ultrasound scan to look at the health of the womb and ovaries, and look at how many follicles you have, which is a marker of ovarian reserve. So then I would certainly recommend that if you're diagnosed with POI, that you are referred to either a menopause or preferably a POI specialist. Now, I know this can be a tricky thing. A lot of our DAISY network members say it is a real struggle, but it is something I would really push for, because the specialists can investigate. They have access to much more resources, tests and knowledge than the GPs do. And the NICE guidelines certainly advocate that everyone should be referred to a specialist. So if you get seen in a specialist clinic, things that I would expect them to do would be a baseline bone density scan to look at your risks, to look at your bone health, look at your risk for osteoporosis in the future. They would do an autoimmune screen to look at anti-adrenal and anti-thyroid antibodies. This can be to look for an underlying cause for POI, and also to see if you do have autoimmune disease, are you at risk of any other conditions. Anyone with POI should have genetic testing to look for an underlying cause. And I suppose because I'm sort of a fertility as well as a menopause specialist, I always like an AMH so I can help advise someone about, you know, the potential for any kind of fertility treatment using their own eggs. But of course, in POI, we're going to expect the AMH test, as it's a marker of ovarian reserve, to come back as very low. And sometimes it can be a really helpful diagnostic tool if there's been confusion because of the FSH levels, which do tend to fluctuate. And then finally, the specialists are going to be able to give you the best advice about treatment options and what's most appropriate to your individual circumstance. So next slide, please. So in terms of management, as I said, I really do strongly believe that all women should have access to a specialist, mainly because we're really fortunate. I work in the menopause clinic here at Chelsea, and we have a dedicated POI clinic, and we've just got access to all these other amazing resources. So like we were just talking, Alice, about counselling. So we have dedicated counsellors, psychologists, psychosexual counsellors, obviously the fertility specialist, dietitians, these things. And I think, you know, POI can be a really complex condition. You know, it's not just about giving HRT and away you go. There's all the other aspects of care, and so I think it's, you know, it's really important to push for referral, to try and see some of these specialists if you can. So in all women with POI, there's sort of general lifestyle and dietary measures that are really important to reduce your risk of cardiovascular disease and osteoporosis in the future. And also some of these things can help with your symptoms, for instance, if you're having hot flushes and night sweats and so on. So everyone should have an adequate calcium intake. This is normally fine if you don't really have any particular dietary restrictions, normally fine to get this in your diet. But if someone avoids dairy, then I normally recommend 1 gram of calcium a day. And vitamin D, I mean, none of us in the UK get enough sunshine, so I recommend pretty much everyone to be on around 800 to 1,000 international units of vitamin D a day. And then just the really simple things like some regular weight-bearing exercise, avoiding smoking, and reducing alcohol and caffeine can all be really beneficial. Next slide there, thank you. So in terms of POI, really the mainstay of management is some form of hormone replacement. So the main cause of all the symptoms in POI are the low estrogen. So we really want to put back those hormones that your body's missing to help the symptoms and also to protect against those long-term risks that we talked about. And it's recommended that you continue HRT until at least the average age of the menopause, so around about 52 years. You don't have to stop it at that point, you can carry it on. But we've had many patients, we've had many Daisy Network members who've said to us that GPs have put restrictions onto their HRT duration around 5 years or so, but this isn't true. The risks from HRT, which incidentally are very, very minimal, but in POI, there's no increase in things like breast cancer with using HRT, because we're just putting back hormones that should have been there naturally until the average age of the menopause. So all the information in those horrible information leaflets inside the estrogen or progesterone, they don't apply to younger women taking HRT. So in terms of replacing the hormones, you've actually got 2 options. You can use the combined oral contraceptive pill and you can use HRT. And just wanted to give you a little bit of details about both of those options. Just next slide, please. So the oral contraceptive pills, often seen as sort of simpler, just a tablet a day. It's something that people are often quite familiar with. Peers may also be on it. And so it definitely has certain advantages, but there is also disadvantages of the pill. Clearly, it's not appropriate for anyone who's still hoping to conceive naturally. And it also delivers slightly more synthetic hormones in higher doses. And most pill regimes have a pill-free week where you're not getting any estrogen, and so the symptoms can return during that pill-free week. There's been 2 really small studies comparing HRT and the pill, and HRT also seemed to have a slightly more beneficial effect on blood pressure and bone health. So generally speaking, I think the oral contraceptive pill can be a good treatment option, particularly for younger women or for a few years after diagnosis. But for my patients, I would certainly recommend in the long run moving over to HRT. But every decision has to be individualized depending on what suits you. Next slide, please. So HRT can seem really complicated, but actually when you break it down, it's just about giving the estrogen that the body is lacking. And then in women who haven't had a hysterectomy and so still have their womb, we also need to give progesterone to protect the womb lining. So there's products where you can combine estrogen and progesterone together, or there's products where you can have them separately, but it's just important to get in those 2 hormones. I don't want to go into the HRT regimens in too much detail, but it's just really important to give the message that women with POI typically need much higher doses of estrogen than in women who've had a menopause around the average age. And again, that's something that often perhaps GPs and things aren't familiar with. So just really important to, not feel scared or worried if you seem to be on quite a high dose. That can be entirely normal. And I always say to patients, when you're trying to pick which preparation to go on to, there's loads and loads of different routes. You can take tablets, patches, gels, sprays, implants. The most important thing for me is that it's a preparation that fits in well with your lifestyle, is giving you minimal symptoms, and you feel that is working for you. there's no clear route of one preparation is better than the other, and it's whatever helps you be able to take your HRT up until the age of 50 and isn't an inconvenience to you. So I think often it's a case of trying several different preparations to find what really suits you best. Next slide, please. Just wanted to mention that sexual function can be a real problem for people diagnosed with POI, and as I said, it's something that we don't talk about very often. So low estrogen can give the symptoms of vaginal dryness, which can make sex quite painful. And women with POI, as well as low estrogen, also tend to have lower testosterone levels, and testosterone is a really important female hormone as well, so for sex drive, energy, that kind of thing. So as well as sort of psychosexual counselling and using decent lubricants and vaginal moisturisers, I could go into this, you know, in more detail if anyone wants to know, or if we've got time, but don't use the KY jelly. That's a really horrible sticky lubricant. Use something like Yes or Silk, much more natural. You can get oil and water-based ones that are much nicer, and the vaginal moisturisers as well. These can really help sexual problems. And then estrogen replacement is really important for sexual well-being. So not just your tablets or your patches, but vaginal estrogen as well can really help and sort of plump up the tissues, make them much more healthy and moist. And then we also quite frequently in women with POI give testosterone replacement. So this can really help with sex drive, energy, that kind of brain fog with menopause. So that testosterone can be really useful for these things. The only problem is there's only this one preparation, Androfem, that's designed for use in women, and the NHS haven't started using that yet, so it's only available privately. So when we're prescribing on the NHS, we have to use these horrible products designed for use in men, but we're very cautious with it, and our aim with testosterone is always to try and keep it within the normal female range so that you don't get any of the horrible side effects you know, that people worry about with testosterone. Next slide, please. So sorry, finally I'm getting onto fertility, which I know we're meant to be talking about, but there's so much to go through. So with POI, I think people are often told, oh, there's no chance of you getting pregnant when you've had POI, but actually 50% of women have return of ovarian function at times. So the ovarian function can wax and wane, particularly in the early years after diagnosis. And so actually around about 5 to 10% of people conceive naturally. And one question that we get asked a lot is it okay to take HRT if you're trying to conceive? And actually in kind of low to medium doses, HRT isn't a contraceptive. And actually the thinking behind HRT now is that by replacing the estrogen, it may actually lower that hormone FSH and LH that we saw that are sent by the brain. And so in theory, it may help to actually promote ovulation. Now, it's not like when you take the tablets that make you ovulate every month, but certainly HRT isn't contraceptive, and also it's going to give you know, beneficial effect on the womb as well. By we would normally use the type if you're trying to conceive where you have a monthly bleed, so it keeps the endometrium, the womb lining, nice and healthy in case you conceive naturally. I'm afraid one of the questions that probably get asked most is there anything that you can do naturally to improve your ovarian reserve or increase the egg count? And unfortunately, at present, there's currently no treatments sort of licensed to increase egg reserve and to increase the chances of natural pregnancy in women with POI. There was a bit of a sort of kind of trend for DHEA a few years ago because there'd been some case reports of pregnancies, but it does still remain controversial, and that's probably something I'd only take if you were under kind of fertility specialist. And again, there's been quite a lot in the press recently about ovarian rejuvenation, stem cells, where they inject stem cells into the ovaries. I think a lot of these things we still just don't truly know whether they're effective and safe, and there've been no large-scale studies. So sadly, at the minute, there's nothing really that we can recommend to try and increase your egg reserve and the chances of conceiving naturally. Other than HRT. Next slide, please. So in terms of the options for fertility treatment, I know Amy sort of touched on some of this a little bit. So one of the tricky things with POI is that the egg count has become so low, and your brain is already sending the FSH messages to the ovaries really, really highly to try and produce more eggs. And so what happens when we try and stimulate your ovaries to produce eggs, to do an egg collection, is that the ovaries don't respond very well. And it can be quite common if you try using your own eggs to, unfortunately, that the ovaries don't respond, or you get very, very few eggs collected. And so unfortunately, there's the success rates if you try and use your own eggs in any of the assisted conception techniques are very low, probably around 5% or less. And so typically we don't really recommend treatments using your own eggs. And so as Amy said, really sort of egg donation, IVF with egg donation has the highest chance of pregnancy, about 50% per cycle. So just for those of you who don't know, egg donation is where we use eggs from someone else, and all we have to do from your point of view is prepare the womb lining using normally some quite simple hormonal treatments. The egg is fertilized with a partner or donor sperm, and then the embryo is transferred into the uterus. I think one of the limitations about donor treatment in the UK is that it's not anonymous. Any child conceived after donor egg treatment has the right to find out who the donor was, and so egg donor numbers are very low, so donor availability can be quite a problem, particularly for people from, depending on your ethnicity. The other side of things is that there's such a bad postcode lottery in terms of the funding for donor treatment for POI, and I think most people end up having to pay to have egg donation privately, which is is ridiculously unfair. Again, we might cover this slightly more in the questions. I think it's probably worth saying that in women who do choose to try IVF using their own eggs, there aren't really any clear sort of studies that say whether that one protocol is better than the other. It's a common question that I'm asked, which protocol which drugs you should use. They've done quite large scale studies into this, and no particular protocol stands out. And so I always think that it's much better, whatever clinic you're going to should individualize the treatment based on your history, your investigation results, and explain to you why they think that particular protocol is most suited. It's definitely not a one size fits all model. And if you're having treatment using your own eggs, you really want to be with a clinic that you feel you can trust, and they're using kind of evidence-based medicine as much as possible, in my opinion. It's worth mentioning a charity called the Donor Conception Network, who at Daisy we've worked quite closely with over the years. For people who are thinking about donor treatment, it's a really fantastic organisation that has loads of information. Obviously there's, people for donor egg treatment isn't for everyone. And so for people who are sort of moving on from IVF with their own eggs or donor eggs, there's options such as adoption, fostering, and child-free living. And another organisation I just wanted to signpost is the Dovecote, really fantastic organisation for sort of positively childless living, and they've got fantastic resources. We mentioned a little bit about egg freezing as well earlier. So unfortunately, egg freezing is quite unlikely to be successful in POI, again, because for egg freezing to be successful, we really need to collect as many eggs as possible. And in women with POI, if we try and stimulate the ovaries, again, we get very, very few eggs to freeze. And so your chances of that actually translating into a live birth are quite low. So unfortunately, it's not really something that I would recommend in POI. Egg freezing definitely has a role for people who are at high risk of POI. And so if you have a strong family history of it, or are about to undergo some kind of medical treatment, then definitely egg freezing makes sense. But once you've actually been diagnosed with POI, unfortunately, it's not normally a recommended option. I think that's I think is there another slide there? Yeah. So yeah, really happy to answer lots more questions about the fertility side of things, because it is hard to sort of generalize for everyone. But there's loads more information on the Daisy Network website as well, particularly about the HRT side of things and long-term health in POI.
Thank you so much, Kate. You
Thanks.
covered a lot there. It was a lot to go through. Thank you. Thank you so much. We're just gonna, I've got one question I'm going to ask you now, Kate, because it came in earlier, before we move on to Sarah. Worrying about low ovarian reserve, so no diagnosis for POI. She's had 3 eggs retrieved, but has low ovarian reserve. She just wants to double check with you what, with testing, what figure would be below normal? Oh, you're on mute.
Sorry, I didn't quite understand. Can you just run that past me again?
So she's had 3 eggs retrieved, but is concerned that she has a low ovarian reserve, and she's just wants to check with the initial test she had to check ovarian reserve, what would be a below normal level? So
typically the test that we do is AMH, that's the anti-Müllerian hormone that I mentioned. It's dependent on your age, so it will decline gradually with age, but very generally less than 5 picomoles per litre is low, and less than 3 is sort of severely low. But it would be also interesting to know her age as well. FSH is a less reliable marker of ovarian reserve, but around about 10 to 12 is normally a sign of low ovarian reserve. And again, antral follicle count, so on a pelvic ultrasound, looking at your ovaries and seeing how many antral follicles there are, so little small developing follicles. Again, less than around 5 to 6 would be considered low, depending on your age.
Fabulous, thank you. And quickly, another one I had sent in prior. High FSH level, has been told that it's unlikely she'll be able to use her own eggs. She says, is it possible now to go and check again her ovaries and her eggs to see if they're what the quality is like? And should she do that?
I mean, I think certainly if this is just based on one FSH, absolutely, as I said, you need repeat tests. Yeah. But FSH isn't a very good indication of the ovarian reserve, so I would always suggest AMH as the more accurate measure. When it comes to quality, though, the most important thing is a woman's age. So you can have low number of eggs, but if you're still relatively young, so if you're less than sort of 35, you'll probably still have quite good quality eggs. So we don't need many eggs in that case. But
she's 27.
So so fantastic. So her eggs should still be good quality. So I would say find out more information and really ask for some individualized success rates from your fertility specialist.
Okay, and she was saying that she was meant to be having an AMH test, but it's never been carried out, so she needs to push for that.
Really helpful.
Lovely, thank you. Now there are some questions in the chat, but I don't know. I think we might move on now to Sarah, and then we'll come back to the questions at the end, if that's okay. So Sarah, if you want to, Sarah's going to be talking about how POI, why it matters in the workplace, and what we should all be aware of, really. Before Sarah speaks, I just wanted to kind of ask Emma, because Emma doesn't have POI, but she's obviously been affected by infertility and for a long period of time. And so Emma, not considering POI now, very briefly, when you were going through fertility investigations and treatment, going into work, was it fine? Were you managing, or were you getting a lot of triggers of different situations and things?
Yeah, it wasn't fine. It wasn't fine at all. Actually, dealing with my fertility in the workplace is probably one of the hardest things, I've had to manage. I just felt incredibly isolated, and I actually felt like I'd lost a lot of confidence not only in myself, but in you know, in how I felt, you know, in relation to being a manager, because I was very open about my my journey, you know, in work, and you know, I had a lot of anxiety around that. I think there's, yeah, you know, we all know there's a lot of triggers. There are triggers everywhere, aren't there? You know, 24/7. But for me, some of the worst and hardest triggers was the staff room. I was just so incredibly difficult, you know, and I tried to avoid the staff room where absolute possible, you know, because there would just be constant chatter, you know, about families, about, you know, weekends and so forth. And the amount of times I made a cup of coffee with tears streaming down, you know, my face, it is just countless, you know, to be honest. You know, pregnant colleagues, very, very difficult, because you can't get away from it in work. You know, when you're in the workplace, you know, like if you're, you know, at home, at least you can say, if you don't feel like you can manage to spend time with friends, you know, who are pregnant, you can at least say, well, I can't make it today. But you can't do that in work. You know, you have to spend 7 to 8 hours, you know, with colleagues who might chat about it all day, you know, and that is a day in, day out, you know, conversation to have to manage. And because I was open, you know, with it, I struggled a lot with insensitive comments, you know, and people trying to give me advice, I guess, but you know, because they had such a lack of understanding of what it was that I was going through, you know, that advice was incredibly difficult to manage, you know, and, you know, in terms of, for example, you know, why, you know, just relax, it'll happen, you know, it will happen naturally. My friend's friend who lives in New Zealand, that happened for her. She went on holiday and, you know, there we go. And there was lots of things like that that I had, you know, that I felt I had to deal with all the time. And there was also things like just injecting at work, you know, having to go through treatment, you know, in the workplace, and having to use the toilet, you know, to do those things. And also things like, because there wasn't a workplace policy, you know, calculating leave. You know, that was a trigger for me, to be honest with you, because I was constantly felt like all I did was calculate my leave to make sure I had enough to manage investigations and treatment. You know, and I could talk about this, you know, for a long time, you know, but that is, I would say, the top. And also big calendar events, you know, big calendar events. You know, we know that Christmas coming up, and I would dread October and Halloween being over with, because that's all that people would talk about. And then it was just trying to manage that, you know, and I think I felt that there was just a real lack of understanding in the workplace. People didn't really understand how difficult it is to go through, you know, and to struggle with a fertility journey, or to go through treatment. And I think, had there been maybe a policy in place, and it had been recognised as, you know, a disease of the reproductive system rather than a perceived lifestyle choice, I think that would have really helped me to manage what we were going through better in the workplace.
Yeah, thank you, Emma. Yeah, we will move to Sarah now, because Sarah's going to just be discussing POI in the workplace, what some of the hidden implications are, and what employers can do. So, you know, we can listen to Sarah now, and then maybe get some ideas of how we can approach our employers and our colleagues to kind of make things a bit easier. So, Sarah, are you happy to go from here?
I am, thank you, and thanks for having me here today. Similarly to previous speakers, I try and get a half-day workshop in 20 minutes. So this is a whistle-stop tour. It's the all aboard the Equality Counts Express for some talk about menopause in the workplace. Excuse me. So I will try and cover the basics that really will help you to start talking about your situation at work and understand kind of what your rights are and what the what employers should be doing. So, and let's have a look to start with at what the business implications are around talking about POI and menopause at work. It is a topic that's often not talked about, But I think there is more conversation in society and employers at large starting to talk about these situations at work. And reproductive issues, menstrual mental health, menstrual conversations need to happen at work, because they are can be debilitating for some people and can cause higher rates of absence when they're mismanaged. They can cause complaints about management, and for some people there is a feeling that whilst you're going through this and struggling with work at the same time, for some people there can be a choice, or to feel that the only option is to leave work. So having supportive workplaces is really important. We have got a rise in employers looking at either standalone policy or integrating guidance and support into existing policies, but this is still only around 12% of employers, so it's not a high number at all. And we can see really that the benefits of having a workplace that is able to support you going through this time is much better for the employer themselves as well as for the employee. And often I'm quite conscious that there's a lot of conversation right now, and being World Menopause Day, about menopause in the workplace. And often what you're hearing a lot of is, I'm not going to say hysteria, but I am going to say hysteria. A lot of hype and hysteria about menopause at work. And I just want you to be mindful that often it's because what you're hearing is almost what you're hearing worst case scenarios. You're hearing stories and tales of people who are not diagnosed and therefore not appropriately treated. So given that you're here today and you may be already undergoing investigations and creating treatment plans, it's good to bear in mind that symptoms are temporary, or should be temporary, and therefore, there should be a return to some normality for you at some point. Although we do need to be mindful of the added, the combined impact here around anxiety and or worsened anxiety and maybe depression around dealing with the transition that you're going through. So just keeping an eye on the chat as well. Are you keeping an eye on the chat? Yeah. Okay. However, some of the symptoms, whilst you're reaching a point of, or a treatment approach that works for you, can mean some extended absences from work. And this may also affect your performance for a period of time as well, particularly in relation to these emotional challenges relating to coming to terms with the POI diagnosis. Okay. And anxiety, depression, and high levels of stress combined can cause, can worsen these performance issues, although that is not the way that this should be approached by your employer. And I noticed Emma said about, absences at work, wasn't it, and having to look at leave, and that's certainly not what you should have to be worrying about, and that should be recognised now that that's not how it should be managed in the workplace. So just some bits of information there about the difference in being in a supportive workplace, basically. And I guess it shouldn't have to be reliant on you yourself as an employee to start talking about your POI status at work. But if you're not in a workplace that has kind of taken up or embraced the conversation around menopause, then you may need to be the person that starts talking, whether that's with directly one-to-one with your manager or with trusted colleagues or somebody else that you trust at work. But clearly there are benefits to being in a supported place, and what we want to try and avoid is you feeling that you have no option but to leave the workplace. And because there are legal obligations from employers as well to support you at work, which we will talk about shortly. But embracing the conversation can be key to you feeling more able to thrive at work during this time. Okay, and however, you're not under any obligation, to tell anyone about your status, but really you're not going to be able to get the support that you need if you don't. So that's why we need some maybe an approach or planning to help you start talking to your line manager. Being mindful that this can be incredibly sensitive and emotional topic to talk about. I mean, I'm sure Emma will agree that whilst dealing with what she was dealing with in the workplace, probably wanting somebody to talk to, but then when you get that conversation and you get that opportunity, it's a bit like going to the GP, all you want to do is cry. You know, it can be incredibly sensitive. So having a plan and approach can be really helpful for you. And I think it's important to know that in the workplace, there are two main strands of law that may relate to your to premature menopause, menopause. The Equality Act protects you against discrimination, and this includes discrimination against sex, disability, and age. And that could be, you know, not just an older person. So it could be the way that your situation is interpreted or dismissed by your manager. So also the Health and Safety Act at work says that an employer must, where reasonably practical, ensure your health and safety and welfare in the workplace. And that includes not worsening or exacerbating any existing symptoms that you have. Okay. So whilst menopause or premature menopause are not specifically cited under the Equality Act, that you are offered protection if your symptoms could be classed as a disability. However, which means that, you know, over a certain length of time, they would be considered to be having an impact on your day-to-day, substantive impact on your day-to-day functioning. However, the guidance for employers would be really not to try and seek, you know, does the situation you're working through, do you fit into that kind of disability umbrella? The approach, really, the best guidance is they should just start offering and working with you to find reasonable adjustments. Okay, and we'll talk about reasonable adjustments very shortly. And in terms of sex discrimination can be unfair treatment, basically, because of your sex. So if your line manager was to sort of dismiss you and take your situation less seriously than they might do if a man went to approach them, or a male worker's health condition could be treated with more seriousness. And there has already been a successful tribunal based on this claim of sex discrimination. Okay. And depending what kind of industry and workplace that you work in, employers also need to be mindful of workplace culture and banter around this kind of condition and status. So that's very important. And, you know, it can be really difficult for you. Like Emma said, if you're the person experiencing this, the last thing you might want to do is to have to be the kind of you know, the bullying monitor, the banter monitor, and have to challenge this. But this is why it can also be really important for you to find at least one trusted person you can speak to, so that you can reach out and say, do you know what, I'm finding these conversations really difficult, or you know, those comments are inappropriate, and to be able to flag it up to somebody then who can maybe speak on your behalf. Because you know, stigma about menopause is at any age is difficult, but having to manage that stigma that you might feel around this at a younger age might make it even more difficult for you to open up and talk about it. So when we're looking at moving on to reasonable adjustments in the workplace, they're basically small changes that will enable you to stay in work whilst you work through sort of a temporary transitionary time. Okay, so they're just changes that reduce or remove any disadvantages you have because of what might be perceived as a disability. Although what we're saying is best guidance is not to try and seek or classify you as disabled, but to just offer you work with you to find these reasonable adjustments, basically from the minute that you say that you need them. So this might include an employer agreeing to record your absence as menopause related absence instead of sickness absence. Okay, and that's exactly kind of maybe what Emma was alluded to earlier. It might also be allowing you more time off for appointments for a short period of time, bearing in mind that these things are hopefully a temporary situation. So it's small changes to enable you to stay in work for a temporary period of time, with a view to the agreement that you've made to being regularly reviewed. Okay. So if we look at some of the symptoms that might most affect you in the workplace. Now, Chelsea and Westminster NHS Trust is actually the symptom checklist that I would most use, and they've got quite a lot of about 30 plus symptoms for or menopause related symptoms on their checklist. But these are some of the symptoms that will most affect people in the workplace. Now, if you add on to this the kind of emotional difficulties that you might also be experiencing, then it's no wonder that, you know, anxiety can feel magnified, and depression may occur as well. And so then you've got brain fog, which is really a combination of all these symptoms. You know, can just leave you feeling unable to focus, you know, struggling to get anything done really. And this is where reasonable adjustments can really be key to helping you to stay in work and to help you through the kind of avoiding lengthy periods of absence, which can quite easily happen, particularly when anxiety and depression is involved. Okay, I mean, I did not experience POI, but I did experience, I had premenstrual dysphoric disorder at the same time as a bereavement of a parent, and really struggled with all of these things combined, and then surgical menopause. So, and I used to have brain fog, which, you know, severe brain fog. But yeah, so I think, you know, you can see that how these things can affect you at day to day in work, whilst you get your HRT probably sorted. And I also know earlier dosage was mentioned. I mean, I'm 50 and I have 2 times 100 microgram patches twice a week, so I'm on a high dose. And but I think that kind of just maybe emphasizes the point of a higher dose not to be feared. You know, I speak to people who say they have a 25 microgram patch, and I'm like, I wouldn't be able to wiggle a toe on that. So and I have testosterone and vaginal estrogen, you know, so I've got the full combo just to be able to get out of bed really. And I'm staying on it for as long as I can with my consultant's agreement. Don't need to come off it. So yeah, it's really important to bear in mind that the symptoms of the menopause do not last forever, and they will gradually subside. It may take a couple of years, and you know, some people, everyone's experience is different. Not all people will experience all symptoms. The severity will differ. Some people will have 1 or 2, some will have none. And it's really just about finding the right balance with your consultant that helps you to feel well and able to function in work. So bringing into that, you know, agreement with your employer, and hopefully, you know, we can keep you thriving, not just surviving in the workplace. Okay. So when we look at some changes in work, these reasonable adjustments that are small adaptations to your job or your working environment that make it easier for you to do your job alongside coping with a health issue. So these can be relevant to you if your day-to-day activities are impacted. Okay, so it could be, you know, insomnia that might result from, you know, until your estrogen levels are better balanced for you, but also from anxiety. So you might need a later start for a while. So you might need a little change there. But these are some of the environmental changes that will help you deal with hot flushes and maybe dry skin, itchiness, bloating, weight gain. You know, so if you have uniforms, you might need 2 sizes of uniform. If you're experiencing, I was going to say poor hygiene, but you know, some people experience hot flushes and, you know, may want a change of clothes to compensate for that. You might need to be near toilet facilities if you're having issues with heavy bleeding. You may have migraines and want to be somewhere where, you know, to have the option of working in a dimly lit office, or a space to go whilst you take medication for a headache and wait for that to settle. So yeah, you might need a private space if you're feeling overwhelmed, and a lot of bigger organisations may offer this. I mean, smaller organisations, it may or may not be more difficult or more easy to cooperate with, but you know, these are recognised solutions to menopause symptoms. So, you know, and employers would be foolish not to try and take these on board if they're what you need. Okay. Facilities are really important. Yeah. So if you do need changes of clothes and so on, asking for those, and even just thinking about things like how you're sitting at your desk if you're experiencing joint and muscle pain as the estrogen from the drop in estrogen. I have to say, like perimenopausally, I had joint pain absolute beyond, and you know, I don't anymore. Okay. And then these reasonable adjustments here are what you might agree with your line manager or HR or your occupational health practitioner. Okay. And I have got an example of how you might apply these. And they're just basically aimed to help you feel more comfortable if you're feeling tired or anxious. Some people get things like pins and needles, so you may want to be able to move away from your desk and, you know, a bit more often, or have more breaks so you can walk around. And they're just things that, you know, with a line manager who's informed and you're able to talk to, you can address these things. They don't need to know about your dry vagina. That's not the kind of role of the manager here. It's not about your intimate symptoms. Okay. And so some of the examples of reasonable adjustments are here. I think it's quite good to be able to see how you can apply them. I think I've got stop there. So can you see that how you can, you know, apply some of these? So, you know, if you're experiencing joint pain, you may need an equipment check and some changes there. Okay. And you want to investigate whether or not your employer already has a menopause policy, a fertility policy, or something that will support you in the workplace, or they may have guidelines incorporated into existing policies. And they should also have some way of including an assessment in their kind of health and safety guidance as well. So they can look at the you'll have the slides later from Alice, but you'll be able to see this better. But they should be looking at some of those environmental adjustments that can be made. And then just thinking about stigma around this, and research really tells us that, you know, what affects stigma are the health-related issues and the gender role-related issues, professional esteem around, you know, are you performing? Are you able to make decisions? Are you thinking clearly? How are you being perceived at work? And then obviously the financial issues. I mean, you know, if you need to take time out, it's the gender equality issue that it affects your income and therefore can worsen not just gender pay gaps, but gender pension gaps as well. And there's additional workplace pressures and worries that can impact stress and leave you feeling worried about not being valued, that you won't be promoted, and being judged for how maybe you look and feel whilst you're going through this, if you're feeling some physical changes as well. Okay. And here's some of the reasons often discussed about why it could be difficult to talk about POI at work. And some people, you know, just feel that it's a private issue. It just might be too overwhelming for you to talk about without worrying that you may, well, you know, emotionally break down in the workplace. And that's, you know, that's certainly something that happened to me with PMDD and bereavement. And, you know, when you're feeling overwhelmed emotionally, it can just almost feel like too much to even, you know, start to broach a subject. Which is why I think having a plan about how you talk to a line manager or finding trusted people within the workplace can be really key and important to you. Okay. In the best case scenario, you'll have an employer like ASOS, who apparently is now paying 10 days a year paid menopause leave in their new workplace policy. But I think we're a long way off before that becomes usual practice. But, you know, in terms of thinking about talking to your line manager, we did say that you don't have to tell anyone about your status, about POI. You don't have to, but obviously if you don't, then it's going to be difficult for you to get the support that is available to you. Okay. So ask for a meeting. I think, you know, obviously it's easy to say these steps are easy and obvious, but when you're overwhelmed and feeling emotional, nothing's obvious and nothing can feel easy. But, you know, if you kind of maybe follow this plan, see if you have guidelines, see if there's a policy in place. If you are wanting to meet with your manager, you can email ahead. You know, depending on the relationship you have, you may want to drop an email and just say, you know, I need to talk about this. This is the policy that I want to discuss. You know, get as much information there ahead. The more that you send your manager ahead of the meeting, the less explaining you have to do when you meet. And find your trusted colleague or somebody to help you plan what you want to say, particularly bearing in mind the things that are most challenging for you in the workplace. Make sure you note the things that you really want to say and that you don't come away from the meeting, you know, so overwhelmed that you haven't actually said or got the solutions that you want. And also think about, what if the conversation doesn't go as you expect? What if the manager or the person you speak to isn't as empathetic as you need them to be? How will that make you feel and how will you manage it? It's, you know, you shouldn't have to think about that eventuality, but it can happen. And the main aim for you in any conversation like this is about you getting the support that you need. And so, you know, doing as much as you can to make sure you come away from that meeting with the solution that's going to help you most. And you'll have this later as well, but have a look at those reasonable adjustments and maybe think what adjustments are you know, most appropriate for what you need right now. And when you create a workplace passport, it can be called a reasonable adjustment passport. It's a temporary agreement that notes the changes that are going to be made. It also can be shared with people above, your line manager and above, not kind of randomly around the organisation, but say you move to another post, it would go there. And it means that you don't have to keep talking about what you're going through. You talk about it once, the changes are noted, and then it's reviewed with your line manager. And if you're not happy to talk to that line manager, you are within your rights to talk to somebody else. So never feel that kind of, you know, dread. Because we've probably all felt it at some time, that the person you need to speak to is like the least likely person you ever want to talk to. So, you know, go to HR and just say, you know, I think you can just say, oh, I'm not comfortable talking about it with that person. Is it okay if I speak to you? You don't even really need to explain why. And I think it's a great idea to just write things down if you can't talk about it. Okay. But yeah, ask for, think ahead, share information. You could maybe share a link to the Daisy Network. I think that would be a great idea. You know, have a look at this tip, Fertility Network UK, and share as much information as you can that's relevant. And then just to include some of the things that, you know, I've had to put in place myself. I had quite a lot of time off or time out after my surgical menopause. I had total abdominal hysterectomy and both ovaries removed, and went back to work with absolute gusto, and then basically I'd burn out a year later from just doing too much, not really talking about what was going on and not taking an approach that really helped me. Burying my head in the sand, I guess. And I think that's relevant to something was that Amy said earlier about maybe not confronting things until later, or not being able to actually deal with the situation until later on. And that's really what happened to me. It was probably just over a year, and then it was like, oh right, this is what's happened, this is where I am now, and having to come to accept where I was at the point that I was in my life. And it was very challenging, actually. And I'm an older person, so I can imagine that, you know, that's just compounded if you're younger. So I think it's really important now is the time to sort of take as much time to plan your self-care is really important. And I'm not talking about drinking a bottle of wine in a bubbly bath. That's that'll alleviate the pressure for an evening, but the long-term self-care to try and help keep you in work can be really helpful. Okay. And then just some little tips, because I know I've yacked on and on and on. I'm sorry, Alice. Some tips on overwhelm. You know, I just say it as it is. Create a crisis plan. You know, people get overwhelmed. I was found once on the toilet floor crying. You know, these things. Life happens, and it can be really overwhelming. Have a plan. Who you're going to go to. Who you're going to call. It sounds like Ghostbusters. Who you're going to ring, you know, who's going to be your trusted mate at work, or who you're going to have on the end of the phone, where you're going to go to walk off your anxiety. Get this, you know, take time to plan this and take it to work with you. And then it is World Menopause Day, so this was one of my tweets this morning about bone health, so keeping your posture at work. Bones are super important. And then I've got some tips on brain fog.
We are coming to the end though, Sarah, just to let you know, I'm worried you're going to get cut off.
I am done now. And sleep, and then a little action plan. So I'll send this to Alice and you can have this later. Thank you very much. Over and out.
Amazing. Thank you, Sarah. You crammed loads in there as well. Thank you. I'm just going to stop recording just for a second because I'm concerned that we're going to run out of time. But we'll carry on with the questions. So thank you so much, everybody, for doing that information session. I will be sending this out to people and a copy of the presentations. Any questions, come back to me by email and I will get your question to the right person. So I'm going to stop recording now. Quickly now,